Let's see the other one. Histological question. Identify the structure shown in the histological image below. What is it? Look at the histological image. Okay, we are seeing multiple layer epithelium. Okay. Then we are seeing some other structures over here. Look like wavy fibers. Could be muscles. It could be muscles. Okay. If you look at this multiple layer, stratified layer, is it stratified squamous? No, the upper layer are not squamous. They are not cuboidal. They are big cells. They are big umbrella shaped cells, pear shaped cells which are located at the top. What this slide could. Now you have a general idea of the slide. Okay, this is like this. Let me see the options. Bile duct. Does this appear like a bile duct? Obviously not. Bile duct will have a lumen. It will have some cuboidal epithelium, but not a muscles and all this. Obviously, you can rule out the bile duct option from here. Then common bile duct again. Bile duct. Skin will have stratified squamous. Stratified squamous. Keratinized epithelium will be present in the skin. Neither it is stratified squamous nor there is any keratinization. Urinary bladder is the answer. This epithelium over here is the transitional epithelium. This epithelium over here is the transitional epithelium, probably from an empty bladder. So you can see this umbrella shaped cells, and this you can understand the detrusor muscles over here, multiple layered and running in all the different directions, because the function of bladder is to squeeze and to pass out all the urine through the urethra. Therefore, the function depends. And why this transitional? Because bladder will be stretched, and you don't want the urine to be absorbed back into the system, right? So you have multiple layer which are transition in nature. That is why it is the urothelium, and that answer over here is our urinary bladder. I hope the point is clear. Let's see the next one over here. Schwann cells. Schwann cells are the cells which are forming the myelination, but in which nerves? Central nerves, CNS nerves, peripheral nerve system, in the peripheral nerves. So Schwann cells do myelination in the peripheral nerves. The oligodendrocytes are the ones. Oligodendrocytes are the ones which do myelination in the central nervous system. Now Schwann cells, as they are present outside the CNS, they have no role with the neuroectoderm. So derived from where? They are derived from the neural crest cells. That should be our answer, and here it is in option number C. This is our answer. If you look at the other options, paraxial mesoderm. Paraxial mesoderm is the one that is going to form the somites, going to form the sclerotomes, going to form the dermatomes, going to form the myotomes, not the Schwann cells. Endodermal cells, no, Schwann cells are not endodermal cells. Endodermal cells basically form the core of the body, gut, bladder, respiratory system, liver, like these structures. Intermediate mesoderm is going to form the genitourinary structures. Genitourinary structures like the kidneys, the gonads, all those structures. Answer over here is option number C. Neural crest cells. Neural crest cell derivatives are itself very important. So what does it form? Apart from Schwann cells, remember few things. It forms all the ganglias except basal ganglia. Basal ganglia is a misnomer. It is a nuclei. Then it also forms Schwann cells, ganglia, then melanocytes. It does form. Adrenal medulla. It does form. Conotruncal septum in the development of heart. It does form over here. Odontoblasts are formed. Like, and you have the arachnoid and the pia matus, the meninges, they are formed from here. So many things are formed from the neural crest cells. They are regarded as a fourth germ layer. Okay, another image-based question. Let's see which of the following structures related to the area marked as A in the image given below. Let us see the image. Area marked A is over here. Okay, what is this? This is lungs. These are the lungs. So which side lungs, right or left? The border that is smooth is always present posteriorly. The border which is flat and compressed by the sternum, that is the anterior border. It's also written over here, anterior posterior. This over here is the hilum of the lung. This is the area for the hilum of the lung. Now in the left lung, this area which is see what happens. This area is the area for the heart, right? Anterior heart. So some structure will come out from here and it will go around over here, go posteriorly. This is where the labeling is given. Now let us see the options to understand. Superior vena cava, but it's present on the right side, so it is the lung, left lung. So you can rule it out. Azygous vein again present on the right side. The arch of azygous vein present on the right side. Arch of aorta is what should be the answer, because that is what is coming on the left side, because here we have the left border of the heart by the left ventricle. This is the arch of aorta. Therefore, this is probably our answer over here. The last option over here is telling us the left brachiocephalic vein. Again, left brachiocephalic vein doesn't form any impression on the lungs. It's going from left to right side across the midline into the superior mediastinum in front of the branches of arch of aorta. It goes in front of the branches of arch of aorta, just behind the sternum. Therefore, our answer is over here is option number C. Right? Tomorrow they can even show you the right lung. So in this they give you a hint by anterior and anterior margin and all. But remember that you have to understand which side lung it is. So the rounded border is always on the posterior aspect, the flattened border is on the anterior aspect. Plus, if you have only one fissure as they are showing over here, it is probably the left lung. If you have two fissures, it is normally or probably it is going to be the right lung. Let's see another one. The lining epithelium of the vagina is vagina. Vagina, that is the lower part of the female genital tract that opens outside into the body. So obviously it's going to be stratified squamous epithelium. So there's stratified squamous. Stratified squamous is also one more stratified squamous. So which one? Normally, if the skin, we have stratified squamous keratinized epithelium, and as you go into the cavities, they are stratified squamous non-keratinized. And somewhere in between the keratinization, non-keratinization, there can be some partial keratinization that is known as parakeratinization. But still, we have to go with one. So we have to go with a non-keratinized stratified squamous epithelium, because it is not completely keratinized. So we can't go with option number B. Therefore, answer will be over option number C over here. Stratified squamous non-keratinized epithelium, that is what is epithelium for the esophagus as well. So upper and lower part of the gut, lower part of anal canal also, though it changes from non-keratinized to keratinized as you go more towards the skin side. Okay. Answer is option number C. Circle of Willis does not get contribution from. Circle of Willis, very important topic. So let us see circle of Willis over here. Circle of Willis, what happens is there is a couple of arteries anteriorly known as internal carotid artery. And there is this couple of arteries from the magnum, that is a vertebral artery over here. Now let's see. These vertebral arteries, they will fuse or they will meet and they will form the basilar artery over here. This basilar artery will divide into posterior cerebral artery. This is the basilar artery. This is all happening in the lower or the inferior surface of the brain, deep to the arachnoid matter. Now this anterior cerebral artery, what it is going to do is, it's going to give the anterior cerebral arteries. What are these? Anterior cerebral arteries. Now see, what is going to happen is that these two anterior cerebral arteries are going to be connected by anterior communicating artery. And the ICA is connected to the posterior circulation via this thin artery that is known as posterior communicating artery. And everyone listen carefully, this is what is the circle of Willis. This is what is circle of Willis. So circle of Willis includes the anterior cerebral, posterior cerebral. It includes the anti-communicating, posterior-communicating, and a part of ICA if you can include this. But then there's one more artery which is many times confused, is that from ICA, the lateral branches, the main continuation of ICA that goes laterally is the middle cerebral artery. It is not a part of the circle of Willis. So if you now look at the options, anterior cerebral artery is forming, contributing, yes. Middle cerebral artery, it is not contributing, it could be our answer. Posterior communicating artery, it is contributing, Answer is our option number B. Got the point? Because it directly goes laterally from the ICA through the lateral sulcus, supplies the lateral surface of the brain. It is not a part of the circle of the Willis over here. Let's see more. A patient developed the following deformity after overhead, that is weightlifting exercises. He developed this deformity. Which of the following muscle is involved? Now you can see over here in this particular, you are seeing the person, you see the right scapula medial border. The medial border of the right scapula is prolonged backwards. Why? Because the muscle which was arise from here, which has to keep the scapula on contact with the ribs, is not working. Which muscle is that? That muscle is serratus anterior. That muscle over here is the serratus anterior. Serratus anterior muscle looks like not working over here. That is what is known as a medial winging of scapula. The medial winging of scapula, and the nerve supplying this muscle is nerve to serratus anterior, also known as long thoracic nerve. Let us see the options. They ask which muscle. They are not asking the nerve. Muscle over is correctly was serratus anterior muscle. Right? Serratus anterior muscle. See what happens if the trapezius is damaged, then there will be lateral winging of the scapula, not the medial winging. There will be lateral winging. Because what is happening? The trapezius is doing what? The trapezius is actually pulling the scapula in this direction. So it doesn't happen that the scapula goes into this direction, and there's going to be more lateral winging of the scapula. But the answer over here is pretty obvious. That is option number B, serratus anterior will be the answer. Which muscle fibers consist of spindle-shaped myocytes? Out of the muscles, which is the spindle-shaped myocytes? We all should be knowing it is going to be smooth muscle over here. Other muscles, see, skeletal muscle are non-branch striated muscles, right, with a peripherally placed nucleus. The cardiac muscle are also striated, but they are branched. Right, they're striated, they are branched, and they have a centrally placed nucleus. Only spindle-shaped nucleus or the spindle-shaped muscle fibers, myocytes, are found in the smooth cells over here. Therefore, the answer over here is pretty straightforward, smooth muscle cells. One of the easiest questions, if I may say so. Okay, upper limb. A patient with leprosy presented with the deformity as shown below. Leprosy patient showing a deformity. What's a deformity? You can see the ring and the little finger, that is the fourth and fifth finger, they are having a sort of claw. Why we say claw? Because if you see, then MCB joint over here is extended and IP joint is flexed. So you can say that, okay, it looks like a medial clawing, right? We have a medial clawing over here. And they're saying leprosy. Leprosy normally involves the ulnar nerve. So it is the ulnar nerve that is involved, and ulnar nerve will lead to medial clawing. Ulnar nerve is also involved in leprosy. So all of these things are saying it looks like ulnar nerve. Let's look at the options. So which nerve? Obviously, the first option is giving us a good idea. It's going to be the ulnar nerve. Radial nerve will lead to wrist drop. The median nerve over here, though it is very less commonly involved in leprosy. Second thing, if there is a median nerve, what will happen is the hand will be like this only. But once you ask the patient to make a fist, then the patient will be able to fold or flex these digits, but this index finger and this middle finger is not that much flexed. Why? Because the lateral half of the FDP is not working. That is supplied to the median nerve, so flexion of these digits is not possible. Benediction sign is what you see in the median nerve injury. Here is you have the ulnar clawing or the medial clawing of hand. That is a part of the ulnar nerve injury. Posterior interosseous is actually a branch again from the radial nerve. Therefore, the answer is pretty straightforward. It has to be about ulnar nerve. Okay, one more, upper limb. 40-year-old with chronic liver disease presented with the complaints of inability to straighten his ring finger completely as shown in the image. Okay, see the image over here. The ring finger is going like this. It's on the lateral aspect, this is going like this, right? That is the problem over here. So ring finger is unable to straighten. The broad sheet-like tendon involved in this condition is, what is involved over here? What is this over here? This condition is known as the contracture of this area, Dupuytren's contracture. What is happening? We have this palmaris longus muscle and that expands into palmar aponeurosis. And sometimes there is contraction of the palmar aponeurosis, and that leads to what we can say as the flexion of the ring finger. It might involve ring finger as well as little finger. That is Dupuytren's contracture of the aponeurosis. Do we have answer? Yes, we have answer. Not retinacle or not rough, it is aponeurosis. The palmar aponeurosis is the one that is at fault over here. This is Dupuytren's contracture. Now what will happen? This finger will go into flexion like this, unable to straighten, because this you have the fibrosis over here in the palmar aponeurosis. Then this is the two interphalangeal joints, the proximal and the distal. Next, what will happen is this proximal interphalangeal joint will also be flexed. But finally, the finger in the terminal stages will go like this. This flexion in the later stages, there will be flexion of the PIP joint, not of the DIP, or the PIP. And the PIP joint flexion, then this finger goes like this. DIP joint is sort of extended. It involves this Dupuytren's contracture involves the ring finger and mainly the little finger, these two fingers mainly, right? So it's probably the aponeurosis, the palmar aponeurosis, hence the answer over here. Good question. The heart starts to beat in the dash week of development. Heart is one of the first organs to start to develop. It starts to beat around the fourth week of development. Embryonic life, if you say, then answer over here will be the fourth week, right, of development. The heart starts to be, that will be the answer. But if tomorrow they ask you about the gestation age, if they ask you about the gestation age, because in clinical we use a term gestational age, and gestational age, which is 2 weeks more, so answer will be around 6 weeks. Around 6 weeks, that is around 36, 38 days from the, if you take the LMP, last menstrual period, gestation age will be around 6 weeks. But here they are asking about simply development, there's embryology, so you have to go with looking for answer number B, 4th week. Next one, a resident was inserting a CV central venous line through the femoral vein. Again, the femoral vein. He accidentally injured the structure medial to the femoral vein within the sheath. If you remember the mnemonic, we made from lateral to medial. N, A, V, E, and L. E, L goes along like this. So they said that they injured the structure medial. So medial to the femoral vein is this empty space canal which is having the lymph node. That is we know by now. Which structure likely to be injured? We know the answer should be canal or the lymph node. Therefore, we have this lymphatic vessels, artery. This is obviously lymphatic vessel because lymph node has to have lymphatic vessels. The lymph node is connecting, having afferent lymphatic and the efferent lymphatics. So lymphatic vessels are the ones which go to the lymph node. Answer is obviously our option number A over here. Femoral artery is lateral, nerve is also lateral, genitofemoral nerve. Genitofemoral nerve has two branches known as femoral branch and your genital branch. Genitofemoral nerve, remember, it has a femoral branch, it has a genital branch. Right, root value of this is around L1, L2. Now what happens to these two? Femoral branch goes along with the femoral artery to supply the sensation on the femoral triangle region. It is again lateral to the vein. The genital branch goes along with the spermatic cord, right? What does it supplies? The cremasteric muscle. Therefore, these are involved in the cremasteric reflex. Cremasteric reflex, where the genital branch is the efferent component, femoral branch is the afferent component normally. If no femoral nerve is given in the option as the afferent, then we can go with the ilioinguinal nerve, right? So, therefore, answer over in this particular question was option number A. Let's see more. Arrange the coverings of the kidney from within outwards, as from inside to outside. From inside to outside, what are the coverings of kidney? 4 options are given in sequential form: renal fascia, capsule, then 2 pounds of fat. Remember, always first of all there has to be a capsule, fibrous capsule. So option number 2 should be over here. So we have these 2 options we have to fight for. That's common sense and smart work. So you only have to see 2, 3, 1, 4 or 2, 4, 1, 3. Then 2 is first one. Okay, after fibrous capsule there is some amount of perinephric fat. So therefore, after 4 comes the 4. After 2 comes the 4. So this option number 4 looks like the answer. Then after it you have the renal fascia or the false capsule. Then most outside you have the perinephric fat. So it is 2, 4, 1 and 3. Yes, that is the sequence going from inside to outside. Remember, renal fascia over here is known as a false capsule. Remember, the gyrotas fascia is this renal fascia. Gyrotas fascia is this renal fascia. Okay. So answer over is going to be 2, 4, 1, 3. A good topic to ask for. Boundaries of Kellett's triangle are found by all except. Remember over here that we had this what we can say the 2 hepatic ducts, then the common hepatic duct, then we have the cystic duct over here, then we have the common bile duct over here. Along with it, you have the artery also coming down over here. This hepatic artery divides into right and left hepatic, and this is the cystic artery over here. Now, if you take these, then actually what happens is this area actually, this is the Kellett's triangle. Okay, it is not involving any part of the liver. What it is involving? It is involving common hepatic duct, yes, over here. It is cystic duct, yes, over here, and cystic artery, yes. These are 3 boundaries of the Kellett's triangle. If you include the liver over here, then that triangle becomes the hepatobiliary triangle. That triangle becomes the hepatobiliary triangle. So obviously, gallbladder is not a content or not a forming any boundary of the Kellett's triangle. It is a cystic duct that forms, not the gallbladder. Therefore, we can easily go with this as the answer, the wrong one over here. Okay, what is the content of this Kellett's triangle? They may ask. Then there is a small lymph node over here called as cystic lymph node, because it is for the gallbladder, cystic lymph node of Lund, L-U-N-D. Right, that is the content of it. Let's see more if we got. Here we have, what are they asking? That image below shows the insertion of the transverse abdominal muscle. Very good. Identify the conjoint tendon. First of all, you should know what is conjoint tendon, where it is found. The lower margins of transverse abdominis muscle fibers and internal oblique muscle fibers, they form the conjoint tendon, which is also known as a fox inguinalis. And what does it do? It forms basically the roof of inguinal canal. It will form the anterior wall laterally and roof, and then the posterior wall medially. So it is like this going over. Suppose the span is the inguinal canal. This is the conjoint tendon. It's fox, sickle shape, inguinalis in the inguinal region. So you have to see where it is actually. Okay. Look at the image. First of all, decipher what is anterior, what is posterior. You can see the ribs, you can see the sacrum over here. This is the muscle which they are saying. The B option is the transverse abdominis, right? A would be the fascia, thoracolumbar fascia, right? Now, if you see over here, then this D is going from anterior superior iliac spine to pubic tubercle. This looks like a inguinal ligament. Therefore, these inferior fibers over here will be the fox inguinalis or the conjoint tendon. Therefore, option number C over here should be our best possible bet over here. Though this view, they can even show you different views. This side view, you only see us on the side view because it is basically present on the anterior aspect. But this will be the most probable location, the inferior fibers of the transverse abdominis and the internal oblique, right? They form the conjoint tendon. In a patient with the referred back pain, so there's back pain, a surgeon suspects the origin of pain to be from the retroperitoneal organ. The organs which are only covered anteriorly by the peritoneum and which are more or less fixed to the posterior body wall are known as retroperitoneal organs. For example, the kidneys, the ureter, the aorta, the IVC, the pancreas, the duodenum, the ascending colon, the descending colon, these are basically all the retroperitoneal organs. I just named a few, most of them. What is most likely cause? Which of the following is retroperitoneal organ? Let us see. Jejunum is totally intraperitoneal. Liver is intraperitoneal. Stomach is intraperitoneal. Automatically answer should be option number D. Let us see what is option number D. Pancreas. Yes, pancreas is retroperitoneal. Along with pancreas, let me just write down over here the kidneys, comma ureter, comma aortas, comma IVC, comma duodenum, majority part of duodenum, comma pancreas, right? Then ascending and descending colons. These are all our retroperitoneal RP over here. These are all basically our retroperitoneal structures. The liver, the spleen, the stomach, the jejunum, the ileum, the transverse, the sigmoid colon, these are all intraperitoneal. Basics should be very clear. Surface marking of the oblique fissure of the lung includes, very good question. Nowadays these questions, they do come. Now see what happens if you look at a person and say on the lateral view, this is ante and the posterior part. Okay. And imagine the lateral view, if you are viewing then on the right side, then imagine this is the lung over here on the right side. Lateral view, right? Suppose I said like this, you are viewing from this side, laterally, right side, because oblique fissure of the lungs, let's see on the right side, both the lungs. There are few surface marking points which are very important. What are those? Those are that if you make a line from say the mid-axillary area and the mid-clavicular area, and that is on the posterior spinous processes. And what actually happens is that this oblique fissure actually should be going like this. What are the surface points? Along the mid-clavicular line, it goes around the 6th rib. Along the mid-axillary line, it crosses around the 5th rib. Then it goes over here. If you ask the patient to abduct the upper limb, then the scapula also will be rotated somewhat like this. And therefore, this oblique fissure goes along the medial border of the scapula, and it reaches over here around the 3rd T3 spinous process. T3 spinous process. This is the approximate area for the oblique fissure. If here we look at the what we say as the horizontal fissure also, then if you go from the 5th rib in the mid-axillary line over here, if you go horizontally, it crosses this area around the 4th rib. That is the location for the horizontal fissure. And this hole is the oblique fissure. Now, if you look at the options over here, 6th intercostal is no, it was 6th rib. 5th rib, yes, in the mid-axillary line, we have the 5th rib, so that looks like option. 7th rib, no, it is not related to it. And all of them, no, not all of them. So, answer will be our option number B. Oblique fissure, you have to keep in mind the surface marking part. The oblique fissure is present on both sides of the lung, that is right as well as left. Horizontal fissure is present only on the right side, normally. Just remember this point. Okay, next one. During evaluation of the patient with erectile dysfunction, ED, it's quite common nowadays, his internal pudendal artery was found to be stenosed. This artery is basically the artery which supplies the perineum. Remember this. Which of the following vessel is this a branch of? So it is coming from where? It is basically coming from the internal iliac artery. Internal iliac artery has two divisions, anterior and posterior. This over here is basically from the anterior division. Let us see the options. Yes, option number A, anterior division of the internal iliac artery. So what actually happens is the internal iliac artery gives off mainly branches which supply the pelvic region, they supply the gluteal region, which supply the thigh also, like the obturator artery, and then it supplies the perineum also. Internal iliac artery is a quite important artery. It basically supplies the areas like, as we said, pelvis and perineum. For this perineum, we have this internal pudendal artery, then the gluteal region, for which are the gluteal arteries, and then the obturator artery that goes to the thigh also. It also does supply the posterior abdominal wall too. How to remember it? See, for the posterior trunk, for the posterior division of the internal iliac artery, the mnemonic is ILS. I is for the iliolumbar artery, L is for the lateral sacral artery, and S is the superior gluteal artery. Remember this. Rest of all the branches come from the anterior division, hence the answer over here is option number A. External iliac artery does give very few branches. One of them will be the inferior epigastric, another would be the deep circumflex iliac, other would be the deep circumflex iliac artery. Iliolumbar will be branched from the posterior division. So over here they are asking us straightforward, the internal pudendal artery is a branch of, you have to answer it is a branch of anterior division of the internal iliac artery. And this internal pudendal artery then goes from the path, it goes from where? See, it is arising in the pelvis, then it goes into the greater sciatic notch, then it enters into the lesser sciatic notch, then it enters into the pudendal canal, then it moves anteriorly to supply the other perineum structures. So it has a path which is quite similar to the pudendal nerve also, and both of them they run in this pudendal canal, both of them meaning by pudendal nerve and internal pudendal artery. Okay. Okay, one more question. The 34-year-old man underwent surgery for an indirect inguinal hernia. Fine, fair enough. During this procedure, the surgeon accidentally injured a nerve which has led to decreased sensation over the anterior 1/3 of the region of scrotum. Okay, you should know the sensory supply of the scrotum, or they can tomorrow ask you about the labia majora, because both are embryologically coming from the similar area known as labioscrotal swelling. So a person was operated for the inguinal hernia, and then he had that nerve which was cut, which lead to decreased sensation in the anterior part of the scrotum and anterior medial part of the thigh. Which nerve? So in the scrotum, we have to understand if this is scrotum, that is anterior and posterior, then anterior 1/3 over here is supplied basically by the root value, that is L1, which is basically very ilioinguinal nerve, and that is coming from the iliohypogastric nerve. Both are having root value L1 only. The posterior 2/3 of the scrotum or the labia majora is basically supplied by the perineal branches, perineal nerve of posterior cutaneous nerve of thigh, and also branches from the pudendal nerve, perineal branches from pudendal nerve. These are the ones that supply the posterior 2/3 of scrotum. Their root values will be S2s or S3s over here. Right? So remember, in the scrotum or the labia majora, the sensory supply is very atypical. Just a small structure. Anterior part is L1 root value. Posterior part suddenly jump to S2, S3. So therefore, if you anesthetize this scrotal area, you know, if you either you give LA local, or you have to go through entire from lumbar to entire everything below the lumbar region. You have to anesthetize, or you have to keep it quite for a while to operate onto it. That is the dermatoma of scrotum or the labia majora. If you look at the options, perineal nerve supplies the posterior part, posterior nerve thigh also supplies the posterior part, iliohypogastric nerve, that could be your best bet. That supplies basically the, what we say as the anterior part of the scrotum or the labia majora. Genitofemoral nerve, yes, that will also see. Genitofemoral nerve, that will also be important part. Why? Because genitofemoral nerve gives off a genital branch. That is interesting. Now here comes the tricky part of the question. See, iliohypogastric itself is not entering into the patient over here. Now look at the clinical question. The patient was operated for indite inguinal hernia. This hernia passes through the inguinal canal. Right? What are the nerves in the inguinal canal? Basically, inside the inguinal canal, we have the spermatic cord, as it is a male. Inside the spermatic cord, the nerve is genital branch of genitofemoral nerve, and the nerve lying outside over here is the, which it actually comes from somewhere over here. This nerve is the ilioinguinal nerve. So this nerve is the ilioinguinal nerve. Right? So if you only think, okay, iliohypogastric is close to ilioinguinal, not, it is not ilioinguinal. Iliohypogastric will give a collateral branch known as ilioinguinal. But then we have option number D also, genitofemoral nerve. This genital branch, genitofemoral nerve branches might reach this area, what this says, the anterior middle region of the thigh and the anterior part of scrotum. Therefore, answer over here will be our D, not C. D is a better answer than C over here. Right? So our answer over here will be D over here, genitofemoral nerve. So that is actually inside. Okay, fine. Now let's see if there anyone else. Yes, where is the sinus of Morgagni present? Topic is pharynx, and you know the pharyngeal constrictors. There are, if you take a coronal section, then there are superior, middle, and inferior pharyngeal constrictors. At the top, you have the base of the skull. The Morgagni is the space between the base and the superior constrictor. This superior constrictor, middle, and inferior constrictor. Here, what we have basically the eustachian tube, and we have the levator palatini muscles. That is where what is sinus of Morgagni. Therefore, the answer over here will be our option number C, between the skull and the superior constrictor. That should be our best possible answer over here. Okay, let's see more. Okay, which of the following marked foramen? Again, a skull question. Does the mandibular division of the trigeminal nerve pass through? Should know, first of all, theoretically, this nerve passes through which foramen? It passes through foramen ovale. Foramen ovale, mnemonic was male, M-A-L-E. This M is the mandibular nerve, A is the accessory meningeal artery, L is the lesser petrosal nerve, a branch of 9th nerve, E is the emissary vein. So first of all, theory should be clear. Eyes see what the mind knows. Now we have to search for what? We have to search for this foramen ovale. Can you find it? Yes. So you should know where is foramen ovale. This foramen is located in the sphenoid bone, basically in the greater wing of sphenoid bone. If you look at the midline, there are 3 foramens over here, which are known as Ross foramens, rotundum, ovale, spinosum. Now we have the information. Now we can understand over here, this is the rotundum. Okay. Therefore, this will be the ovale, option number A, that is ovale. And option number B will be the spinosum. So answer basically is our option number A. First of all, let us mark the answer, then let us look at the image once more. What are the other options over here? See, option number C is a foramen in the pitrous part temporal bone, that is internal acoustic meatus. And option number D is a foramen between the temporal bone and the occipital bone. This is the jugular foramen. This is a jugular foramen, right? So these are the foramens which you should know. Identify the foramen ovale. That is our option number A. It will be our answer, right? So guys, that was all. I hope you enjoyed PYQs. Any problems, any queries, you can ask us over. Okay, that's all. Thank you.